So what kind of inspired you or prompted you to actually apply for one of the community grants?
Yeah. So one of the taglines of the community grants is empowering practicing allergists and removing barriers to care. And I think really those two values really undergird the foundation of my motivation for this project with penicillin allergy delabeling. So, up to 20% of the population has a penicillin allergy label. And so that means that in all of our communities, there's a significant number of patients who are really unnecessarily bearing the burden of the morbidity and again, burden of avoiding penicillin when they don't need to. So you take that and then you add in the fact that, there's under 6,000 practicing allergists in our communities. And so really a lot of patients may not have access to penicillin allergy testing. And so really then this project is thinking about, how can we push the ball forward in both those avenues to help empower practicing allergists while removing barriers to care. So with regards to empowering practicing allergists, really my goal with this grant, this project was, trying to explore what other tools can we add to both allergists' armamentarium as well as just the community healthcare in terms of just navigating penicillin allergy and kind of equipping them, because again, no single medical discipline can bear the burden on their own. And so how can we equip allergists to be able to help guide and coordinate with their colleagues within the community to help manage that? And then in terms of reducing barriers to care, really just expanding penicillin allergy testing to the pediatrician's office.
Okay, so you're not trying to replace the allergist?
No, not at all. Not at all. I think, even just the numbers by themselves, if there was an allergist who wanted to exclusively take care of penicillin allergy in their community, I don't think they would even be able to.
Okay. Yeah, I tend to agree with you. I think it's overwhelming. And so that's why your project, which I should remind people is really a planning grant from that standpoint to say, okay, what's the need? What can we do about it? And get some initial data. Was great. So what have you learned so far? You're into this now almost 3/4 of the way through.
Yeah. And so maybe even before I talk about what I've learned so far, would it be helpful for me to kind of explain more about the project?
Sure.
Good. So essentially what we're looking at is, can we do direct amoxicillin challenges in pediatric patients who have a penicillin allergy in their pediatrician's office when they're coming in for a routine kind of healthcare visit. And so we're doing a prospective study trying to include patients who, again, are already coming into their pediatrician to do graded amoxicillin challenges. We're excluding patients who have a history of severe cutaneous adverse reactions to penicillins. And if they're eligible and they agree to participate, that essentially they'll go through a 2-step amoxicillin challenge with a 60-minute observation period. And during that observation period is when the pediatrician will do their well child check or their routine follow-up visit. And then that's really it. There's a 7 to 10 day post-challenge follow-up that we do over the phone to assess for any delayed reactions. And our primary objective is really just looking at how many patients can we perform amoxicillin challenges in their pediatrician's office. And then we have a number of secondary outcomes. So we're looking at the percent positivity rate of challenges in that population. We're looking at patients who have negative, so don't have any immediate or delayed reactions, and we're able to remove their allergy label. And then we're going to look 1 year later, how many of them still have the label off of their chart. And then we also want to look at what are the reasons why parents are hesitant for proceeding with this recommended amoxicillin challenge. So kind of a few different things that we're looking at. So then back to your question of what have we learned so far? So far we've screened 90 patients and we have, so 58 of them have been eligible, 39 have expressed interest in participating, and we've completed 15 amoxicillin challenges. Of those 15, none of them have had any immediate reactions within the office. One patient had a mild delayed rash that was resolved with oral antihistamines. So overall, the initial data has been encouraging in terms of just the feasibility, like can we do this within the clinic logistics that we're in effectively. And so that's been encouraging. Another thing that we've learned has been the importance of targeted kind of education around penicillin allergy and testing with that. So as I mentioned, one of our secondary outcomes was looking at, why are families hesitant to proceed with this testing? And so for the families who declined to participate, but were willing to participate in our survey, so we had 19 of them, and of those, 80% were concerned that if they proceeded with testing, that could actually lead to a more severe reaction. 50% were concerned that even if they had negative testing, that their child would still be allergic to penicillin. And 50% really didn't see any adverse effect to their child's health from avoiding penicillin. So I think highlights the importance that both allergists and pediatricians will have in terms of educating families about penicillin allergy.
Well, and it points to where we have to put our education. Again, we don't have all day with these patients somewhat, and in talking with the patients up front that we're going to be talking to, you're elucidating what we need to cover, which I think is going to be very useful for us from that.
And I think also in terms of just how, as we build up the tools to evaluate penicillin allergy, I think it's gonna be really interesting, where, if say the child acquires their label in the setting of their pediatrician's office, then in that same setting, where that same pediatrician is providing education around that, would there be increased uptake? And again, just increasing access to penicillin allergy testing across the context of the community.
Yeah, and I don't see it as removing the allergist. I see it as basically using the allergist as the expert. Because there's going to be those patients who aren't going to fit for this protocol exactly, or need more education or more reassurance that then the pediatrician could send on to the allergist.
Exactly. And I think you had alluded to this before, that I think part of the goal is to remove some of the overwhelming factor, because it can be overwhelming in terms of the sheer numbers. And so if we can sort of even just triage, where do we need the allergist expertise to plug in with those individual cases, as well as where do we need the allergist expertise in terms of coordinating, just all this testing. I think that throughout this, the allergist maintains a really crucial role in terms of being the main spoke for coordinating these efforts.
Do you see this going forward eventually as an outcome of having maybe some type of a roadmap or a toolkit for an allergist for his or her community?
Yeah,
basically say, look at this was done in this great community grant. Maybe I want to do this in my city. Here's a roadmap for me.
Yeah, I definitely think so. I think that the different tools that the allergists will have to be able to kind of plug into different specific aspects that are unique to their context will be helpful, because there won't be a one-size-fits-all option. And so I think as allergists work with the relationships they have, whether it be with outpatient pediatricians, or it be with inpatient hospitalists, as they navigate, different questions that may come and how they navigate that, I think this can be a really important tool that they have to implement within that context.
So right now you're working with pediatricians.
Correct.
What about family practitioners? Have you thought about kind of expanding this to them?
Yeah, I think that that's a great next step. And so the impetus really with starting pediatricians has been where I've had the experience. And I think that really points to, again, at allergists building on the relationships they have. And this certainly is not unique to pediatricians, but I think can be expanded to really all aspects of primary care.
Yeah, a lot of the data that's come out has been more on the pre-surgical patients, that have been driving this to try and de-label penicillin allergy. So internists and more of the internal medicine allergists have had some experience with this, but I think you're hitting it from a different end, which is great, coming at it from back in the pediatric population to see where you can hopefully de-label some of these people.
Yeah, and again, I don't think there's going to be a kind of a magic solution that automatically wipes out all of these, but it's going to be more of those. How do we utilize multiple pronged attacks to be able to help reduce kind of the total burden within our communities?
Well, I like the fact that you're going to be surveying those patients who initially say, "Yeah, I'm interested," but then don't pursue it completely, and are going to be able to tell us, well, what are their roadblocks? What are their hurdles that we have to get over? Because they all would qualify. And
Exactly.
we need to move them. And maybe you're going to find a population that say, I'd feel more comfortable in an allergist's office.
Mm-hmm. Yes, no, completely. And I think that then being able to triage and being able to prioritize those referrals was really helpful, not only for allergists, but even for pediatricians to be able to help navigate those.
Excellent. Do you see any other gains for the community allergists from your study?
Yeah, I think those two are the ones that I've anticipated, and I really think will hopefully play out. Again, increasing the options that allergists have to guide, again, fellow providers in their community to navigating penicillin allergy. So I think, yeah, just further equipping and providing those will be able to help them navigate just different kind of situations that come up and what's going to work best for their community. The second piece, and we've already alluded to this, but again, the education part, and with our limited time, where do we need to focus? Like, do we need to do more education in terms of, you know, the adverse effects that can happen if you're avoiding penicillin unnecessarily? Or do we need to talk more about the actual testing, like the safety and the efficacy of the actual challenges? And again, where can we triage our time to be most effective, I think is still not clear. And so are hopeful to be able to add to that understanding.
Well, and I also see, I think this is of value to the community allergist as something we can go forward with and say, here's another service I can offer. As the community allergist in this community, I want to be your resource. So for you in family practice and pediatrics, I'll work with you and let's figure out how we can do this in our community. And I think that now you're going to have hopefully a published article when you get this all done and we have it published in Annals. It'll be something they can reference to and be able to take. So I think it's fantastic.